And we have different hormones. Of course, we have the steroidal hormones. Of course, we have the hormones that are the steroidal hormones. We do have the reproductive hormones and so on. And all we are saying is that these hormones, you can either synthesize agonists or you can synthesize antagonists. And once you do so, then you will prevent those hormonal molecules from activating the specific biological processes in the body. So we're looking at hormone therapy, and we can say hormone-based therapies are used for cancers which are hormone dependent. For sure, for you to use hormone therapy to treat a cancer, the cancer must be hormone dependent, and we're going to look at a number of them. If the cancer cell requires a specific hormone, then a hormone can be administered, which has an opposing effect. In other words, that cancer requires a certain hormone so that it can develop or it can proliferate. Now, if you use an antagonist, then definitely you will stop that cancer from going on. Alternatively, hormone antagonists can be used to block the action of the required hormone. So that's what we are saying. Either you can use the agonist, because when you use the agonist, then you oversensitize the receptor and you get the negative feedback mechanism. Or you can use the antagonist and block the receptor. Steroid hormones combined with intracellular receptors form complexes that act as nuclear transcription factors. So the steroid hormones are important in triggering or in bringing about that nuclear transcription. They act as nuclear transcription factors. Steroid hormones control whether transcription takes place or not. So that is the need for the steroid hormones, that they have an influence on transcription. And therefore, if you block the activity, then again, you will block transcription. And therefore, of course, you will bring about cell death. So therefore, we are saying in this introductory slide that you can either have agonist or you can have antagonist. But the cancer in question must be sensitive to a certain or a specific hormone. So we look at different hormones. We look at the glucocorticoids. You look at the androgens, you look at the progestins, you look at the estrogens, because those are the hormones that are normally important that have been found to be important in the processes of cell division. Those are the ones that have been found to be important in the process of the cell division. So glucocorticoids, prednisolone. So you can have prednisolone, you can have prednisone, you can have hydrocortisone, you can have dexamethasone, you can have methylprednisolone. So these are the glucocorticoids, and you know what glucocorticoids are. These are the ones that have an influence on the glucose and even have an influence on the minerals. So like dexamethasone is a very potent mineral corticoid. So these are the glucocorticoids. They have an influence on the glucose levels. And prednisone itself is a prodrug. It is converted to prednisolone by reduction of the ketone at position number 11. So it acts as a prodrug and is converted enzymatically to prednisolone in the body. The glucocorticoids such as prednisolone and dexamethasone have marked inhibitory effect on lymphocyte proliferation. So when you talk about lymphocyte proliferation is defined as a process where lymphocytes begin to synthesize DNA. So if you inhibit the activity of glucocorticoids, especially, remember we are looking at mainly in the abnormal cells, in the abnormal cancer cells, you inhibit the lymphocyte proliferation, then of course you will inhibit DNA synthesis. Used in the treatment of leukemias and lymphomas, the ability to lower also raised intracranial pressure and to mitigate some of the side effects of anti-cancer drugs makes them useful also as supportive therapy. They decrease the intracranial pressure, which may increase during, let's say, like brain cancer. So therefore, that can also help, and they can be used as supportive therapy, even when you give other drugs. But we are also saying they also have their own mode of action, where we have said they have inhibitory effect on lymphocyte proliferation, and they are also needed in transcription, and hence once you give these drugs or the antagonists, then definitely you will have some anti-cancer activity. So that is what I have for the glucocorticoids, not much. The estrogens also, but I think we are going to look some of them, you look at them later. Estrogens inhibit the production of luteinizing hormone, and by doing so, decrease the synthesis of testosterone. We're going to look at that in a little bit more details. The most commonly used agents are ethinyl estradiol, diethyl stibistro, phosphestro. In the is the diphosphate prodrug of diethyl stibistro. We're going to look at this. It's just a summary. Progestin used as anti-cancer agents include medroxy, progesterone acetate, and megestro. Again, we're going to look at that. Androgens are thought to suppress luteinizing hormone, resulting in a decrease in the estrogen synthesis. These include, again, we are going to look at all that in details. That was just a summary. And this is what, when we talk about the steroidal drugs, like we have looked at prednisolone, ethinyl, estradiol, all those drugs have what we call the steroidal nucleus. And this is what we call the steroidal nucleus, where you have those 4 rings. So you have 4 cyclic rings, cyclohexene rings. At times they can have unsaturation depending on which steroid you are looking at. And then, of course, you have that cyclopentane ring. All of them fuse together, and that gives us the steroidal nucleus. The numbering, we start from there, number 1, 2, 3, 4, 5, 6, 7, 8. Quite simple, 9, 10. And then from that 10, you go to 11, 12, 13, 14. So it's just a continuous thing. 15, this should be 16 and 17. So that whenever we look at a drug and that drug has that basic structure, then we call it a steroidal drug. And of course, this was just to show the numbering of the other substituents that you can have within that drug. But that is a basic, very important steroidal nucleus. And when we look at some of the drugs we're talking about the glucocorticoids, the estrogens, the progestins, and the androgens. Again, we are going to look at them in their specific category. So this is a structure here. Pointer again. Going to look at them again. So here, there, of course, that is our prednisolone. And if you look at it as prednisolone, we are seeing at position 11 in prednisolone, you can see we have a hydroxyl group. At position number 11 of prednisone, we have a ketone. And we're saying that is the difference. Prednisone being a prodrug converted into the body, into the prednisolone, which is the active drug. So these are glucocorticoids, and you can see that the glucocorticoids at this position here, mainly what makes them differ is that structure there, and even the structure on the first ring. Usually the substituents on the first ring and the substituent at, we say that was the topmost position, is position number 17. So the substituents at position number 17 and also at position 1, 2, 3, at position number 3, and the first ring A, this is ring A, B, C, D. So the substituent at position number 17, at position number 3, and even the type of ring you have as a ring A determines what kind of a steroid you have. It determines the kind of steroid you have. So we've already said prednisone and prednisolone. The difference is just at position number 11, they are glucocorticoids, and you can see at position number 17, they have an alpha hydroxyl group, and then they have a hydroxyl methyl ketone at that position. When you look at now, this is the estradiol. This is an estrogen. That is an estrogen. And if you look at estradiol, one of the striking difference is that the ring A, which is this one, is usually a benzene ring. So for all estrogens, ring A is a benzene ring. And of course, you can also see that they are also differing in the group that you have at position number 17. And of course, also the group that you have at position number 3, as we have discussed. You should be able to discuss these compounds where you are discussing them as, you should be able to discuss in pharmaceuticals, glucocorticoids, on the steroids. You're supposed to discuss the non-steroidal, the steroidal anti-inflammatories, and I hope you are able to look at the different structures if you have discussed that. So you can see that, of course, they have main differences. We are seeing main difference at position number 17, and of course, as I had said, in the type of ring A, and of course, the substituent at position number 3. So that is estradiol. This R can be changed, And if it is changed and you have a C triple bond CH, C triple bond CH, then that's what you call ethinyl estradiol. Ethinyl estradiol is usually important in delaying the metabolism of the of estradiol, because that hydroxyl group is highly susceptible to a metabolism, and therefore you put a group there, the ethinyl group. And once you put the ethinyl group there, it is important in blocking the metabolism of the hydroxyl group, the oxidation of the hydroxyl group, because once that group is oxidized, then that drug ceases to have estrogenic activity. So that is the difference between estradiol and ethinyl estradiol for the purposes of making it orally active, and of course also making it have a longer duration of activity. Most of these drugs, because of the many basic groups, the hydroxyl groups and so on, that like that ketone, that hydroxyl group, you find that they do not have oral. Most of them do not have oral activity because they are rapidly metabolized. They are rapidly metabolized and therefore will not give us good activity. Then you have what you call the diethylstilbistro. If you look at it, this is the trans. If you look at this is a trans isomer, whereby here you have the double bond. You can see this hexene 1, 2, 3, 4, 5, 6. So if you count the carbon, that's carbon 1, carbon 2, carbon 3, carbon 4, carbon 5, carbon 6. So you have that is the hexene molecule. That is a hexene molecule. And the molecule that, or the conformation that has been found to have activity is the trans conformer. It's a trans conformer. Of course, we're talking about geometrical isomerism. And this is because when you have the trans conformer, of course, that's when you have, that is the ethyl group. And the ethyl group are on opposite side. Also, the hydroxyphenyl group and the hydroxyphenyl group are on opposite side. So the big groups are on opposite side. And when you have that trans, the diethylstilbistro, it has the, you can see there is some structural resemblance between this. You see that it has, if you are to close, these rings, if there is some, if you close that ring there and you close there, you find that the trans diethylstilbistro gives some close resemblance with estradiol, and therefore it has been found to also have estrogenic activity. Then we have the progestins. You can see we have medroprogesterone acetate. Again, you can see the difference there, and you see the difference there. And of course, here you find that this are not alcohols. Unlike the glucocorticoids, these are not alcohols. They are ketones. They are ketones at that particular point at position number 17. And you can see the progestins are both the medroprogesterone acetate and megestro. And you can see again their structure at position number 17 and their structure at this position at that ring also is different from what you have, because it is similar. This position is similar to the glucocorticoids. If you see that is similar there for medroxyprogesterone. Actually, not very similar. It's only similar for, this group there. But you can see this one has a double bond there. So as we had already said, that ring is different from what we have there. And of course, at position 17, of course, you can see these compounds, as we are saying, they are oxo derivatives or carbonyl derivatives or ketones, unlike the glucocorticoids, which are alcohols. This also, now from there, we go to the androgens, and you can see, of course, the main drug there is testosterone. And of course, again, there will be some difference in the structure. Again, you can see the testosterones will have a hydroxyl group at this position, R1. Because this is only that it's testosterone propionate. But if it was testosterone, this would be a hydrogen. So again, a difference and the group that we are having at position number 17. And because of that difference, then that steroid brings about a different activity. Then we have dihydrotestosterone, which will come across. And the hydrotestosterone, you can see the difference. It's at position 1, 2, 3, 4, 5. Position 4, 5 has been saturated to give us the dihydrotestosterone. So it is a metabolite. It is a metabolite of testosterone. So those are some of the steroids that we're going to be mentioning. But what was important in this one is for us to appreciate, to be able to compare the different steroids and their structures, and to appreciate, of course, as you've already done this, as I've earlier said, to appreciate that the different structures, there are some different structural differences between the different steroids, which gives them their differences in their biological or pharmacological, in their biological activity, giving them differences in their biological activity. So let us start with the estrogens. And of course, as we said, that you can either use an antagonist or an agonist. And you find that estrogens are physiological antagonists of the androgens. That means if you give an estrogen to a male, it will work as an antagonist of testosterone. And that has been used in management of some of the cancers. So estrogen is a physiological antagonist of the androgens that's used to antagonize the effects of androgens in androgen-dependent prostatic cancer. So if you have an androgen, it must be androgen-dependent. If you give that patient estrogens, of course, the estrogens will have a control or will inhibit the prostatic cancer. Of course, the only problem is that estrogens, of course, given to males, will develop some feminine characteristics, of course, which is a very big person who get hot flashes and so on. So they too develop some side effects, of course, which are not very good. But the cancer itself also, it's bad enough. The agonist is occasionally used to treat prostate cancer through suppression of testosterone production. Also, diethyl silbestro and ethinyl estradiol are two estrogens used clinically in the palliative treatment of androgen-dependent prostatic tumors. The latter compound has fewer side effects. That is the ethinyl estradiol. The ethinyl estradiol is structurally similar, very structurally similar to estradiol. The ethyl silbestro has been found to have severe toxicity. It's completely synthetic. Of course, this is semi-synthetic and having much lower toxicity. These tumors are also treated with gonadotrophin-releasing hormone analogs. We will see that when we get there. Estrogens can be used to recruit resting mammalian cells into the proliferating pool of cells, thus facilitating killing by other cytotoxic drugs. We are only saying when you give the estrogens to these patients who are having these tumors, this prostatic cancer, they will recruit the resting mammalian cancer cells. So when you give estrogens, this must be, of course, to when you have breast cancer, can be used to recruit resting mammalian cancer cells into proliferation. So remember, so you're saying that the resting cancer cells can be able to be activated to divide. Remember, we were saying most of these drugs act very well when the cells are dividing. Most of these anti-cancer drugs, the other ones we have discussed, act best when the cell is dividing. And therefore, if these resting mammalian cells are activated to divide, then they'll be exposed more to other cytotoxic drugs, as we have already discussed some of them, to other cytotoxic drugs, and therefore make the treatment more effective. So you are saying you can't give the estrogens in combination with other cytotoxic drugs so that you enhance the treatment. So this is now mentioned diethyl silbestro, and as we have mentioned, diethyl silbestro, one, of course, it is a synthetic estrogen. It must be the trans diethyl silbestro. It is the only one which acquires the shape, the size, the shape that is required for it to bind the estrogen receptors, just like estradiol. So that the trans diethyl silbestro has the right shape to bind the estrogen receptor like estradiol. It is an olefinic compound, olefinic because of the double bond, that is trans-hex-3-ene. And we are calling it trans-hex-3-ene because 1, 2, 3. Its hexene is 1, 2, 3, 4, 5, 6. So if you look at this, all of this, something like that. That has 6 carbon atoms, and at position 1, 2, 3, respective of which, it doesn't matter despite which side you count from, 1, 2, 3. So it's a hex-3-ene. in which the hydrogens, so one of the hydrogens here, another hydrogens are replaced at position 3 and 4 with para-hydroxyphenyl groups. So that I think is quite clear. It is rarely used because it has been found to have very high toxicity. So if you give it for breast cancer, because we have said you can't give it, when you give an agonist, an estrogen agonist, then what happens? The cells that produce luteinizing hormones will be oversensitized, and therefore through feedback mechanism, because it's an agonist. So whenever you give an agonist, you have what we call feedback mechanism kicking off. And once you have feedback mechanism kicking off, it means that you will stop production of the luteinizing hormone. So that means you will also stop production of the estrogens, and hence definitely you will handle the cancer. So, but unfortunately, it was found to have a lot of toxicity. It causes infertility, miscarriage, ectopic pregnancy, preeclampsia, preterm birth, stillbirth, infant death, menopausal prior to age 45, breast cancer. So in itself, it is also a trigger of cancer. It is also a trigger of cancer because if it will also, it is in the periphery, it will also be able to act as an estrogen and therefore trigger the cancer and also a trigger. So it's carcinogenic in nature. So indeed, it is actually very rarely used. It's very rarely used, especially because of the development of better drugs. So that is some of the drugs that are used. I've talked about ethinyl estradiol. The introduction of the ethinyl group allows that molecule to have oral activity, and by blocking the metabolism of estradiol. And then you have also the estrogens. That one is already, we have already discussed that. So we have discussed that. Then you have also the anti-estrogens, and all the anti-estrogens, all those that block the estrogen receptors, and this one also, we also call them selective estrogen receptor modulators. And you have drugs like tamoxifen, aloxifen, which are also synthetic agents which antagonize estrogen receptors and prevent estradiol from binding. The antagonist direct, they will go there, block the receptor, and the estrogens will not bind. And since the estrogens are the ones that are helping in the breast cancer proliferation, then for sure you will have stopped that cancer. And of course, when we also said in the male, it can also work. Selective estrogen receptor modulator have both estrogenic and anti-estrogenic effects on various tissues. So that's one disadvantage, that they can have estrogenic and anti-estrogenic effects on various tissues. So if you are using an antagonist, then you must be sure that the tumor you have is estrogen. It's an estrogen positive sensitive. It is sensitive to estrogen. The tumor must have been sensitive to estrogen, because if it's not sensitive to estrogen, then even if you give an antagonist, it will not matter. So when you are using the antagonist, you must be careful that the tumor that you are trying to treat is actually estrogen dependent. So it binds to estrogen receptors and induces conformational changes in the receptor, therefore blocking, as we have said, the estrogen from binding. Has anti-estrogenic effect on the breast tissue, and that is good. The ability to produce both estrogenic and anti-estrogenic effect is most likely due to the interaction with other co-activators. So it can be able, we are just saying, it can be able to bring about either, can be able to bring up, can be able to be an agonist on the estrogen receptor, or it can be an antagonist. So it can have the two activities as you have. So it is not a pure. So some of these antagonists are not pure antagonists. They have both the antagonistic activity, but they can also act themselves as estrogen agonists. And that, as we have said, can be a major disadvantage. Subsequent to tamoxifen, estrogen receptor binding, subsequent to tamoxifen estrogen receptor binding, the expression of estrogen-dependent genes is blocked. So once you give tamoxifen, it will bind the estrogen receptor positive receptors and therefore block them, and therefore the estrogen will not be able to bind, resulting in decreased estrogen response. Most of the tamoxifen effect occurs remember we had talked about the anaphase. We had talked about anaphase, where you have G1, you have G2, and then you have the M phase. So mainly occurs in the G1 phase of the cell cycle when you are producing most of the enzymes and so on which you require to synthesize the DNA. So indeed, tamoxifen, therefore, we can say it's cell cycle dependent. It's cell cycle specific. So most of the tamoxifen effect occurs in G1 phase of the cell cycle. Tamoxifen can be used as primary therapy for metastatic breast cancer in both men and postmenopausal women. Patients with estrogen receptor positive tumors are more likely to respond, of course, to tamoxifen. We already discussed that. When used prophylactically, tamoxifen has been shown to decrease the incidence of breast cancer in women who are at high risk for developing the disease. Selective, so that's, I think that all we have discussed. Selective estrogen receptor. So those are the. Let us look at the structure. So this is our tamoxifen. You can see the tamoxifen has a very similar structure with diethers to bistro. Very similar structure with diethers to bistro. There is a hydrogen for tamoxifen, and this is a methyl. So that's where it differs. This was a hydrogen for diethers to bistro for tamoxifen. That is a methyl group, and then of course for sure it differs in that it has this group, dimethyl amino ethyl oxo group. So it has also that group there, which definitely is not found in ethers to bistro. And because of this bigger size, the fact that you've got additional groups that further increase the size of tamoxifen compared to diethers to bistro, then tamoxifen becomes an antagonist, but as well also is an agonist because of the structural similarity with the estrogen. It has the agonist activity and also the antagonist activity. You can also have 4-hydroxy tamoxifen, where the X is a hydrogen, and the for tamoxifen, X is a hydrogen, this R here is a methyl. So that this is CH3, CH2, just like in ethyl to bistro. So the only difference is here, that is also a hydrogen. That's a correction. For 4-hydroxy tamoxifen, where X here is a hydroxyl group. That's a hydroxyl group in place of a hydrogen in the tamoxifen, and also R also is a methyl. So in the hydroxy tamoxifen, definitely that's the only difference. You can also have toremifene, where X is still a hydrogen and the R is what is different. Instead of a methyl group, you have a CH2, CH2Cl. So the methyl group, one of the hydrogens of the methyl group, has been replaced with a chloro group with retention of activity. So those again are the derivatives of tamoxifen, 4-hydroxy tamoxifen, and toremifene. We are saying due to the structural modification of the ethyl to bistro, because they really look like ethers to bistro, due to the structural modification of ethers to bistro, where you have an added group, the molecule is more bulky, then that molecule is able to have both antagonistic, it binds the receptor more firmly, and therefore it is able to have both antagonistic and also agonistic activity, can be used for those cancers that are estrogen dependent, or where you have receptors that are ER positive. Then you have the other drug, which is laroxifene. It has quite a complex structure, can't really see so much of the structural resemblance with estrogen, but it has also been found to have both agonist and antagonist activity. Then you have the fulvestrant. Fulvestrant has been found to be a pure antagonist, as compared to the other two. So those are the main compounds that we are talking about. So we are therefore having, that's why I decided we look at the structures, as we have the pure estrogen antagonist, And the pure estrogen antagonist is the full phase strand. Full phase strand is a pure estrogen antagonist. It does not have any agonist activity. It inhibits the estrogen receptors, and again prevents the binding of this estrogen into these receptors. It inhibits estrogen receptor dimerization and prevents interaction of the estrogen receptor with the DNA. Estrogen receptor is downregulated, resulting in more complete suppression of the estrogen receptor responsive gene function. So in simple form, all we will say is that it will block the estrogen receptor, and in blocking the estrogen receptor, it will prevent the estrogen from binding, and therefore be able to stop the growth of the cancer or the proliferation of the cancer. You can use it for metastatic estrogen receptor positive breast cancer in postmenopausal women. Again, it has to be the positive. It must be the cancers that are estrogen dependent. So we have already looked at the structures. Then from there, we are looking at the different ones. Of course, we did mention, so we have looked at the estrogens, we have looked at the anti-estrogens, and now we also have anti-androgens. And under the anti-androgens, we do have several of them. We have flutamide, bicalutamide, we have cyproterone acetate, abiraterone acetate, which are also semi-synthetic steroids. So the anti-androgens or androgen antagonists prevent androgen again from expressing their biological effects on responsive tissues. Again, the cancers that they will be able to inhibit are those cancers, again, that of course are sensitive to the androgens. Anti-androgens alter the androgen pathway by blocking the appropriate receptors, competing for binding sites on the cell surface, or affecting androgen production. So they will again act at the receptor. They will also block production of the androgens, and therefore that's why we are calling them anti-androgen, either by receptor blockade or blocking the production of the androgens. They are also used in management of prostate cancer, because remember, the prostate cancer is sensitive to testosterone. So if you block the testosterone, if you block testosterone production, if you block the site for testosterone, then you'd expect the cancer to shrink, because it's like it feeds on it. It is activated by testosterone. So that's what we're saying. You will use them. You can use them to treat prostate cancer. And you have an example like cyproterone. Cyproterone is a steroidal derivative. Let us look at the structures. Here you have the flutamide. Then here is cyproterone. You can see that is progesterone analog. So you can see that is a steroidal analog. And then you have abiraterone. And if you look at abiraterone, it brings in a new dimension here. It has a pyridine ring. At position number 17. So we are therefore saying this are steroidal analogs. And you can see also this position 1, 2, 3, 4. 1, 2, 3, 4, 5. At position number 5, cyproterone has a chloro group at that position. So we are just looking at those two groups, the cyproterone, abiraterone, those being steroidal derivatives, whereas flutamide is a totally synthetic anti-androgen. So we're looking at cyproterone it's a steroidal anti-androgen, as we have already mentioned, suppresses the action of testosterone and its metabolite dihydrotestosterone on tissue. So it will sit on the receptors and therefore block both the activity of testosterone and also the dihydrotestosterone. It acts by blocking androgen receptors, which prevent androgens from binding to them. It also suppresses the luteinizing hormone, which in turn reduces the testosterone levels. Remember, the luteinizing hormone is the one which stimulates the production of the testosterone, so it blocks the luteinizing hormone. It also will block the androgen receptors, so therefore testosterone will not sit on its receptors and hence decreased androgenic activity. And we are saying prostate cancer is a result of high levels of testosterone. Of course, once you do this, there are many things that will happen. You will, of course, in these patients, you decrease libido and all those negative effects, because testosterone is what is, of course, responsible for the male activities. I mean, characteristics, for the male characteristics. So the minute, of course, you block the androgen receptors, of course, you will have quite a number of undesirable effects. So this is to the structure of cyproterone acetate and metabolism. It is primarily metabolized in the liver. It is metabolized by cytochrome P450 enzyme, especially the 3A4 enzyme. Of course, that's a cytochrome P450 enzyme or mixed function oxidase enzyme, forming the active metabolite 15-beta hydroxy cyproterone acetate. So indeed, cyproterone acetate is actually a prodrug. So it is metabolized to give us the 15-beta hydroxy cyproterone acetate. And you can see that position there. There you have that, what we're calling the 15-beta hydroxy group. So nothing else changes. Nothing else changes. And again, let us be reminded, we are giving these drugs in their form of the acetate form. The acetate form, when you give them as the acetate form, you can see this was a hydroxyl group. You give them in the acetate form, esters will increase lipid solubility. They will increase lipid solubility by blocking the hydroxyl group. And of course, in blocking the hydroxyl group, they increase on the lipid solubility, and therefore that compound becomes more stable and ready and available for absorption. So we are saying cyproterone acetate is a prodrug. It will be metabolized in the liver and converted to the 15-beta hydroxy cyproterone, and that is what is active. And please note that it is through the acetate forming the active metabolite. 15-beta hydroxy cyproterone retains its anti-androgenic activity but has reduced progestational activity. So that is of great advantage, that once it's converted into the 15-beta hydroxy cyproterone, it also loses some of its toxicity, and it is more potent. It has much higher anti-androgenic activity compared to progesterone activity. It is a derivative. It's a steroidal progesterone. As I had said, if you look at its structure up there, it has a ketone. You can see this group here. It has an acetyl group. If you look at it, it has an acetyl group, and that is why I had said it's a progesterone derivative. It is a derivative of progesterone. It's a steroidal progesterone, and that's why it also has progesterone activity. It offers clinical benefit to patients with hormone refractory prostate cancer. It's administered as an acetate salt prodrug because it has a higher bioavailability and less susceptible to hydrolysis than abiraterone itself. Remember, abiraterone has a hydroxyl group. Hydroxyl groups are very readily metabolized. So once you give it as the acetate, one, you increase its lipid solubility and therefore better absorbed. Two, it is slightly stable than it's more stable than the hydroxyl group in terms of metabolism, and therefore much more readily available. So it's administered as the acid because it has a higher bioavailability, that is lesser. It has higher lipid solubility, higher lipids, and less susceptible. It has higher lipid solubility. It's less susceptible to metabolism, and therefore it is more available. It's more available. If you look at the acetate, please note, look at the acetate. This is a hydroxyl group here that you have made into the acetate, but it still has the acetyl group there. So it has the acetyl group there. So you have hydrolyzed this. I mean, you have esterified you have added an acetyl group to the hydroxyl group to form an ester. And in this case, we are saying the ester is more stable to metabolism than the hydroxyl group, and therefore giving this drug giving it better potency, because once you improve on the bioavailability, then you increase on its stability. It's an orally active inhibitor. course, orally active inhibitor. That's why it's an acetate of the enzyme we call cytochrome 17A1. So it's an inhibitor of the steroidal enzyme cytochrome P17A1, or so that enzyme is also known as 17 alpha hydroxylase / carbon 1720 lyase. So that the whole name 17 alpha hydroxylase / carbon 1720 lyase. We'll be able to look at what that enzyme does. So it will inhibit this enzyme. It inhibits that enzyme. The cytochrome 17A1 is a selective and irreversible. It inhibits it in a selective and irreversible manner via covalent binding. And this enzyme catalyzes the biosynthesis of androgen and is highly expressed in testicular, adrenal, and prostatic tumor tissue. Again, see the word tumor here. And this is the only minor selective toxicity we have. That some of these enzymes have got higher concentrations within the tumors. So when you give these drugs, they will go more for the tumors than for the normal cells. Some of them will still go for the normal cells, and no wonder the toxicity that we see. But they will go more for the tumor cells, and we are saying that this enzyme is the one that catalyzes the biosynthesis of androgens, and it is highly expressed within the prostatic tumor cells. So when you give, of course, this drug, it will be blocked. We're going to see then what it does. The abilateron inhibits the conversion of 17 alpha hydroxy pregnenolone. So 17 alpha hydroxypregnenolone to dihydroepiandrosterone. So you have the 17 alpha hydroxypregnenolone converted to dihydroepiandrosterone that is catalyzed by the cytochrome 17A alpha. You block it, and once you block this, you require the DHEA for the synthesis of the androgens. So that will block the synthesis of the androgens. It has a pyridine ring. Remember, I showed you the pyridine ring. Of the abilateron plays a key role in its action by interacting with the ion of heme in the enzyme active site. So the pyridine ring, we can't say is of importance in interacting also with the receptor. It helps the pyridine ring further increases the binding of this drug to the receptor, and of course its receptor is the enzyme cytochrome 17A1, whereby it will block the conversion of the pregnenolone to the dihydroepiandrosterone. And once you block that, then you will not have the synthesis of the androgens. And this is what we are talking about. This is our pregnenolone. It's a pregnenolone. And the pregnenolone will undergo reduction. You look at it, it will undergo reduction. Its position has been reduced here. In fact, it's undergoing hydroxylation. So the pregnenolone will undergo hydroxylation at, again, position number 17. So you can see that position 17. Again, I hope you did this, when we were looking at, there's a unit we used, Tambosana, I think. There's a unit which has how you synthesize these steroids from cholesterol and so on. I hope you have done that unit. Or you have done the steroid, as I have said, the steroids. Hope you looked at the steroids. So we are starting with pregnenolone, and through a cofactor, the NADPH and oxygen, of course, you do hydroxylation, again, of position number 17, and you get your 17 alpha hydroxypregnenolone. And once you see nothing else changes, and once you get that, that is again acted on. Again, if you look at that, you see, then if you look at this, the difference between this is that, of course, this group here is hydrolyzed, and you have a ketone at that position. So again, using NADPH and oxygen, then you find that this compound is actually like it's undergoing oxidation at that position. And in so doing, remember at this position for the androgens, you have a hydroxyl group. So in so doing, look, that position is the same. The only place which has mainly changed is that here you still have a methyl group as in testosterone, but what is mainly different is that group there where we have a ketone. And of course, in the androgens, of course, you you have a hydroxyl group at that position. So in that way, you form the dihydroepiandrosterone, and that is the mechanism in which you generate the dihydroepiandrosterone, and you require that dihydroepiandrosterone for the synthesis of the testosterone. So you can see the DHEA is then converted to the 4-dione. You look at this again. This is a hydroxyl group converted to a ketone there. And of course, the enzyme is a 3-beta hydroxysteroid dehydrogenase. 3-beta hydroxysteroid dehydrogenase converts, and it's 3 because it's position 1, 2, 3. It converts the hydroxyl group, which has beta orientation. Remember, it was a dihydroxyepiandrosterone, and then so that hydroxyl group is converted into a ketone. Nothing else happens. And then the 4-dione, then using 17-alpha hydroxysteroid dehydrogenase, it gives us the epitestosterone, and also it can also go this way. So here it started with the 3B HSD, and then you get the 17-alpha HSD. So it can also start with 17-alpha HSD and give you the epi15 diol. You can see this is the epi15 diol, and then it uses again the same enzyme. It's just going the other way around. 3-beta HSD, and it gives you the testosterone. So that is how. So once you block, so we did mention that you block the earlier enzyme. You block this enzyme. You block the enzyme that is responsible for producing the DHEA. Once you block the enzyme responsible for producing the DHEA, then for sure you will have blocked this process. That process will not go on, not unless if you have this compound. So if you don't produce that compound by using the enzyme, the drug that is blocking the production of that compound, then for sure the synthesis of the androgens is going to be stopped. So that's all we are saying. So that's why I thought it was important for us to understand how the enzyme, how the drug works. We're blocking that enzyme, cytochrome 17A1, and that is the one which is responsible for production of the DHEA, and you require the DHEA for the production of androgens. So if you have lower levels of androgens, then if this person is having an androgen-sensitive prostate cancer, then you will be able to stop its proliferation or its growth, because you will have stopped the production of the testosterones or the androgens. How is it metabolized? The first thing, so we have, this is our abiraterone acetate. That is the our abiraterone acetate. Was our first drug. That's another drug. Don't wonder. So yeah, I think I'm done with cyproterone. Yeah, we had already mentioned this metabolism. So we are done with that. The metabolism is the active metabolite. So now after that, we have the second drug. Our second drug was abiraterone. So this is our second drug, which was abiraterone. We were discussing that one, I think. Yes. We were discussing cyproterone. Yeah, we were discussing cyproterone, and we are done with that one. Sorry, when I mix them? I mix these drugs up. Oh, this one. Sorry. We have already discussed this cyproterone. Sorry for that confusion. We already discussed our cyproterone and finished. It gave us 15-beta hydroxycyproterone acetate, which we said had anti-androgenic activity. And then we went to abiraterone, and it's the one we have been discussing. Yeah, sorry, I thought we had it. So, and that is the one we have said it blocks the DHA, so that's correct. So there it's metabolism. Okay, its metabolism. It is hydrolyzed into its active metabolite, again, abiraterone via esterases. So this is our abiraterone acetate. So it is in the body. Remember, again, we did mention, remember, this is the one we said it had a pyridine group at that position. And it is an acetate. It is an acetate for the purpose, again, even just like the other one. It is an acetate for the purpose of better bioavailability, higher lipid solubility. You also protect the acetate, will also protect the group which is here. And in protecting the group that is there, that group is not prone or susceptible to metabolism. And the resultant compound, as we have said, when you add this methyl group, it has slightly higher lipid solubility, and that drug can be given again as an oral drug, hydrolyzed. So, but remember, the acetate is also a prodrug. So it active metabolite that, and once you get your abiraterone, the abiraterone can be metabolized into different compound, depending, can be different, can be metabolized by different enzymes, and it can be metabolized by this as sulfotransferase, bring in a sulfate there, abiraterone sulfate. So, of course, the first of all, hydrolysis occurred. That is a drug that has activity, and then it can undergo sulfate conjugation. So, what we call sulfate conjugation, and it will undergo sulfate conjugation. When it undergoes the sulfate conjugation, you can see the sulfate moiety can actually be ionized. That increases the water solubility. The drug leaves. Then it can also be oxidized at the pyridine nitrogen to give us abiraterone N oxide there. And again, once that happens, sometimes some of these things happen to terminate the activity of the drug. Then, of course, the N oxide can also undergo sulfate conjugation, sulfotransferases, and that again, the drug has good water solubility and is removed from the body. So the main routes of metabolism is sulfate conjugation and also N oxidation. So it can be oxidized by cytochrome 3A4 and sulfotransferases, further metabolizes abiraterone into two inactive metabolites called abiraterone sulfate and then oxidase abiraterone sulfate. The first one is an esterases, and then, of course, the others as we have indicated. So this enzyme here is cytochrome P450 for the oxidation or for the N oxidation. So those are the structures as we have looked at. So we have looked at that drug, and we have this one we said it's a progesterone, but once it is metabolized through removal of this group there, then it loses most of the progesterone activity and acquires mainly androgenic activity. So that we had already discussed. The next is the aromatase inhibitors. All these are enzymes. Of course, aromatase, you look at the structure of the estrogens and you compare to the others, you find the estrogens ring A has an aromatic group or is a benzene ring, and that's why we are calling them aromatase inhibitors. So you do require in one stage of the synthesis, you do require conversion of the first ring, which is a non-aromatic, into an aromatic ring. So if you block the process of aromatization, then you will not synthesize the estrogens. And of course, again, you don't synthesize the estrogens. If the cancer is estrogen dependent, then you will have stopped its growth. So aromatase either block the production of estrogen or block the action of estrogen on the receptors. Aromatase is a membrane-bound enzyme, and it has two proteins, consisting of two proteins. It has a cytochrome P450 enzyme. Remember, you're calling them proteins because enzymes are made of amino acids, so they're actually proteins. So cytochrome P450 enzyme containing a heme, cytochrome 19, also a reductase enzyme using NADPH as a cofactor. So we have the cytochrome P450 portion and also a reductase enzyme using NADP as a cofactor. So it has those two proteins or those two enzymes. So it has these two enzymes bound together and those are the ones that are responsible for the activity. Catalysis is the last stage in the biosynthesis of estrogens from androgens, where an aromatic ring is formed, that we've already said. Catalyzes conversion of androstenedione, androgen precursor, to estrone or estrogenic hormone. So you can see, so androstenedione, this is an androgen precursor. It cannot change to estrone. The difference between androstenedione and estrone is that the estrone has the first A as an aromatic ring, whereas androstenedione does not have. You can have classification of these drugs into different generations. You have the first generation, where you have the aminoglutathione. You have the second generation. We have quite a number of them: formestane, fadrozole, rogletimide. Those are the second generation. And you have the third generation: exemestane, letrozole, and anastrozole. So you have the again generations are usually indicate the time of synthesis. And the higher the generation, usually the newer the molecule. Aromatic inhibitors are used in the treatment of breast cancers and ovarian cancers. In postmenopausal women, breast and ovarian cancers require estrogen to grow. So once you give them aromatase inhibitors, you give these women aromatase inhibitors, you will block the synthesis of the estrogens, and therefore you will stop the growth of either ovarian or breast cancers. Can know whether you have looked at the structures. These are the structures. So here you have our androstenedione there, which is a precursor. It's an androgen. It is a precursor of the androgens, and you can see for androstenedione, X is a ketone, so it will be a double bond. X will be an oxygen, and also Y is also an oxygen. So therefore this will be double bond oxygen, double bond oxygen. So for androstenedione, and that's why we are calling it andione. For androstenedione, this is an oxygen, that's an oxygen. You can see everything else is very similar to what we have for testosterone. That's a methyl group, that's a methyl group, just as in testosterone, and that group is the same we have in testosterone. In testosterone, as we have already said, X will be a hydroxyl group, and this will be a hydrogen. So that's the main difference. So when you talk about androstenedione, it does the aromatization, and what we can see here is it's mainly changing that ring there. So from a cyclic ring to an aromatic ring, and of course that would go further pathway or further stages to become, of course, our estradiol or our estrogen, because our estrogen X is a hydroxyl group, that's a hydrogen. So it would undergo estrone. X and Y are ketones, so that estrone will go further biological activity to give us our estradiol. But we require the estrone as a precursor for the synthesis of estradiol. We require the androstenedione as a precursor for the estrone using the aromatase enzyme. We look at the aminoglutathione, that is a drug, completely synthetic. Anastrozole, I've just given a few of them, again, completely synthetic. Letrozole, completely synthetic. And formestane, that indeed, formestane is, again, a steroidal drug. Those are the compounds that we are looking at.